Esta es una sesión muy especial a la cual pues el profesor Fabio Silvio TACCONE ha accedido a acompañarnos en esta jornada. Vamos a tener la posibilidad de disfrutar de una charla muy interesante sobre la actualización del uso del electroencefalograma en los pacientes críticos. El doctor TACCONE pues tiene el plan de poder interactuar y poder desarrollar un taller con nosotros durante el transcurso de esta próxima hora como pues teníamos programado originalmente. Y antes de iniciar, quisiera dar un agradecimiento muy especial a Nihon Koden y al grupo Amarey por el apoyo que nos han ofrecido para poder desarrollar esta sesión en particular. Entonces, bueno, pues el profesor TACCONE viene de una sesión súper interesante que acabó de finalizar en el bloque anterior, en los debates de hemorragia intraparenquimatosa. Y pues bueno, le damos nuevamente la bienvenida. Esta es la segunda oportunidad que hemos tenido el chance este año ya de compartir, al menos virtualmente. Esperemos que la próxima pueda ser presencial. Y bueno, el profesor TACCONE es el jefe de la unidad de cuidado intensivo neurológico en el Hospital de Bruselas con la Universidad Libre. Y bueno, pues bienvenido nuevamente, profesor TACCONE. El agradecimiento infinito de todos los asistentes. Y bueno, el auditorio es suyo. Por favor, adelante.
Muchas gracias, and I apologize again. I promise that if you invite me in Colombia, I will be on time at the moment of my lecture. So let's go with this topic on EEG monitoring in the ICU. This is my conflict of interest. I'm a scientific advisor for Nihon Koden, which is a company producing EEG, but I also have an intellectual conflict of interest, which is the fact that I'm not a neurologist. But as an intensivist, I try to understand the role of EEG in the monitoring critically ill patients and how EEG can help us to better take care of these patients and understanding the pathophysiology of the brain disease in those patients. So I will try to make with you 5 points, which is the evolution of EEG. EEG 1.0 is something that we know. It's very important to monitor brain function. This is a very old manuscript and book published in French on the left side from Fishgold and Matisse, discussing the role of EEG in the evaluation of patients with a coma. And we know now that different critical care societies recommend the use of EEG, some cases of continuous EEG monitoring, in those patients with a status epilepticus where you suspect that there are ongoing seizures and the status epilepticus has evolved towards a non-convulsive status epilepticus. The EEG monitoring can also be used to titrate the therapy to be sure that the status epilepticus is under control. And when you're giving more medication, you can use the EEG to titrate down the number of drugs that you give to control the status epilepticus and then allow the patients to recover. So the 3 societies recommend EEG to monitor these patients. Now, what we also know is that the role of a continuous EEG is relevant in particular for seizure, because if you use continuous EEG, you are able to detect the most of the non-convulsive seizure occurring in the ICU patients. We know now that 90% of seizure in the ICU are not convulsive. People could say, yes, we have a randomized clinical trial published recently by my friend Andrea Rossetti, who said that the continuous EEG doesn't improve outcome of patients where this monitoring is used when compared to intermittent EEG. But again, the question is, you are using EEG not primarily to change the outcome of these patients, but to detect the presence of seizures. So this is the main reasons why you do it. And compared to intermittent, continuous EEG will allow to detect most of the non-continuous seizure in these patients. Now, of course, the problem is that should we monitor everyone for 2 days? The response is not. There are risk factors like history of seizure and the clinical status of the patient, which deserve a prolonged monitoring period. So if you have no history of seizure, you arrive at the hospital after a first convulsion and you are not you're not comatose, then you can go for, let's say, half an hour EEG monitor. But if you have an history of seizure and you are comatose after the initial convulsion, then you need a prolonged monitoring at least 2 days to be sure that this patient is not going into a non-convulsive status epilepticus. So the clinical status of the patients allow to titrate the duration of monitoring in this setting. Is it a relevant seizure? Yes, because it is associated with hematoma expansion after intracranial hemorrhage, with hippocampal atrophy after traumatic brain injury, with a metabolic distress after SAH. So it's not only just electrical activity, but this electrical activity has consequences on our patients. Very elegant paper from Columbia University, Jan Klassens, showing that there is an occurring of seizure here. You see that this is the sympathetic response, increased heart rate, increased blood pressure, increased CCP respiratory rate, and you see that the ICP will go up, and the brain oxygenation, bulb saturation, and PbCO2 will go down. So clearly showing that when there is a seizure, there is a non-compensated increase of blood flow, which will result in tissue hypoxia. And if not controlled, this prolonged tissue hypoxia can, of course, induce neuronal death. The seizure burden, which is the duration of seizure on continuous EEG in different diseases, is associated. This is a large cohort, again, from Columbia, with an increased independent risk of poor outcome. So it's not just a matter of giving a drug, it's just electrical activity, is the severity of disease. When you take into account the duration of seizure, the fact that the seizure is prolonged can be associated with poor outcomes. So it's very important to control seizure and monitor them in these patients. And finally, the continuous EEG monitor can also help to decide to change therapy, to initiate therapy, sometimes to stop anti-convulsive therapies when the patient which is comatose has not seizure on the EEG. So in this case, that will not be indicated. So the EEG is important for diagnostic and also to guide the therapy. So in conclusion, the 1.0 EEG is the detection of non-convulsive or minimally clinical relevant seizure, which are 90% of the patients into the ICU. You will see in this video a subtle movement of the fingers, which is the only clinical manifestation of the seizure. It's important because according to the continuous EEG, you can detect 90% of this alteration. And of course, very important, some patients have abnormal movement in the ICU. Thanks to the EEG, you can also identify patients who do not seize despite abnormal movement. And in this case, you will avoid giving these patients inappropriate anticonvulsive therapies and looking for the cause of this abnormal movement. Now, the 2.0 EEG evolution is not only seizure, but detection of alteration using EEG in the ICU patients. You know that the amplitude, the frequency of the EEG is proportional to the amount of blood flow arriving to the brain. And if you have a significant decrease of CBF, you will have a reduction of the power and an increased lowering, of course, in the most severe case, a totally suppressed EEG background. So you can use as an indirect measurement and monitoring of CBF. A clinical case of a patient after subarachnoid hemorrhage. This is the left and the right side. You're not an expert of EEG. You see that the frequency and the amplitude of DG here on the right side is different than this left side, which looks more attenuated. These patients had a left mid-cerebral artery vasospasm with the still a presence of mismatch on the perfusion CT scan, which which was adequately treated with intraarterial vasodilator. And of course, the patients improved and also the EEG totally improved. You can see how this EEG can be helpful. Of course, is it widely used as a detection of a vasospasm and delayed cerebral ischemia? The response is not. There are 7 studies showing that is a very good specificity and a decent sensibility to detect DCI after SAH, in particular when there is a large slowing of the background and an asymmetry of the signal. These EEG changes can precede sometimes 2 days in advance the clinical deterioration. But of course, the results are very dependent on the feature of EEG that's been used and on the accuracy of the reader to implement this monitor. In my hospital, when we have the chance to have experienced neurophysiologists with the 24/7 availability of EEG reading, we have included continuous EEG monitor since the intermediate risk of vasospasm patients with GCS of 15 and just a lot of blood on the CT scan after SAH as one of the monitor to early detect DCI in these critically ill patients. EEG is also relevant today to prognosticate after cardiac arrest. Patients admitted to the hospital after resuscitated cardiac arrest with this kind of continuous and normal voltage EEG has 85% probability to recover consciousness after the withdrawal of sedation. Patients with this background of suppressed and burst suppressed and burst, we call it burst suppression background, or this fully suppressed and persistently suppressed background. These are predictors of very poor outcome, and these backgrounds are now integrated in the international guidelines as a strong predictors of outcome in these cardiac arrest patients. And in this study, for example, the specificity of this background was 100% to predict poor outcome in a large population of cardiac arrest patients. Of course, EEG is also relevant to predict a good outcome, which we don't have so much. I show you this paper, which is here. So a reactive and continuous EEG has, as I told you, 80% probability to detect patients with good outcome, which is very relevant. And the new information we're trying to evaluate whether this EEG is probably the only only variable available at bedside that can, in the setting of cardiac arrest, differentiate patients with a high probability of good recovery or poor neurological outcome. The third point and the role of EEG, of course, is the fact that there are changes on the background that we call generalized or lateralized periodical discharges, which has been frequently reported in critically ill patients. And these discharges as initially considered as non-interpretable and non-applicable at the bedside. But we know now that having these periodic discharges is, again, like seizure, associated with tissue hypoxia. Of course, these are data coming from SIH, where you can use the invasive neuromonitoring to understand brain physiology in accordance with the occurrence of these periodic discharges. But again, to show you that these are not benign background of EEG, and we might try to understand the role of these periodic discharges and how to treat them, because that can potentially change brain physiology. The fourth application today of EEG is to monitor the depth of anesthesia. We have several guidelines from the anesthesiology society showing that EEG-based anesthesia can reduce the risk of burst suppression, potentially reduce the risk of post-surgical delirium. And of course, it's quite logical, because when you have too much propofol or too much inhaled anesthetics, you might result in this burst suppressed or suppressed EEG, which just underline an excessive sedative use. And we know that in the ICU, excessive sedative use is not only associated with delirium, with many, many other potential complications, as underlined in this publication from Jean-Louis Vincent and the ECASH group. Of course, there are different monitors. We can use maybe simplified or processed EEG at the bedside to quantify the amount of changes in EEG amplitude and EEG frequency as a consequence of sedation. Of course, all these systems are available in UR, and we need to validate their role and their impact when monitoring of anesthesia is done in critically ill patients with prolonged period, because these devices are not validated in these patients. So this is what everyone knows. The 1.0 seizure, the 2.0, the extension of the indication of EEG to detect other changes in brain physiology and brain pathophysiology in critically ill patients. Now, which is the 3.0 EEG, which is the evolution of the application of EEG in the ICU? Well, is the fact that we need to apply it at the bedside as a continuous monitoring. We need to understand what it is to make it a real monitoring system, potentially guiding our diagnostic, our prognostic, but also our therapies. So the EEG is one of the available non-invasive monitoring, which is complementary to other available tools, either invasive or non-invasive. Of course, it's the advantage we have a spatial and temporal resolution of the brain, which is not easily done with ultrasound or with focal monitoring like, ICP, PBO2, and macrodialysis. And so it's a large potential, and it can give, again, a very nice view of the brain with evaluation of changes not only in brain physiology, but also changes on brain function according to therapies. Now, the first question is, this is, of course, a full 21 electrodes EEG applied to critically ill patients. Should we use this montage to all ICU patients? Because this requires a lot of time to be placed on our patients. Can we use simplified montage, which will, of course, increase the number of patients that we can monitor and also reduce the length of EEG application? Well, it depends what you are looking for. If you're looking for monitor of sedation, if you're looking for prognostication, you're looking at basically continuous EEG or suppressed EEG or burst suppression, 6 to 8 electrodes is probably enough. So if you're looking for this issue, then a simplified EEG montage will be relevant. If you're looking for detection of seizure, and sometimes the seizure are just focal, then you need a 21 electrodes, because a simplified montage will probably underestimate the occurrence of seizure in our patients. If you're looking for SIH, as I told you that the occurrence of delayed cerebral ischemia might be focal, then you need to have a full montage EEG to be sure that they're not missing, of course, focal ischemia in these patients in a very early stage, which of course might be underestimated with the use of a simplified montage. So importantly, there is no a perfect montage for all patients. And if you look at the risk, at the, let's say at the balance between the length of installation and the accuracy of data, according to the issue you're looking at, you can choose for a full montage or a simplified montage. The second question is that, okay, now we have the device, now we can decide the type of montage we can use, but can we monitor all the patients where EEG is indicated? It's a very nice letter published on intensive care medicine a few years ago, where the authors look at all the ICU patients in their unit, and they saw that 20% of those met the criteria published by the European Society of Intensive Care to receive a continuous EEG monitoring. But only 27% of those patients could be monitored. And the main reasons why the others were not monitored, because there was an overburden. Either there were not enough devices, or technicians, neurologists, and physicians were too much work to also take care about the EEG installation and EEG interpretation. So there is clearly a gap between those patients where EEG is indicated and the EEG, and these patients where EEG can be done. How can we solve this problem? We can have more devices. So if you have a lot of money, yeah, you can have a lot of devices in your ICU, but also you need more trained personnel, technicians and neurologists and neurophysiologists, who are able not only to turn on the device, but also read the monitoring few or many times a day, maybe sometimes even be on call during the night, to provide the ICU physician an adequate interpretation of the EEG monitor. The availability is one issue in some hospitals, so you have more devices, more personnel, but this service is not available 24/7, which is again a major limitation to the implementation of the EEG into the ICU. And of course, you might go for easy-to-use solution, and we'll discuss this at the end, where this might increase the number of patients with a solution that again is applicable if you have a patients where a simplified montage and the use of processed EEG might be an issue. The other point is that if you have more devices, more personnel, 24/7 system, still reading the EEG requires a lot of time, because you need to read hours and hours of this tracing. So what the technology has provided us, which is the evolution of EEG in particular for the ICU patients, is all this processed quantitative EEG, is the analysis of the raw EEG tracing, which is transformed in an analysis of power or frequency over time. You see here that the frequency of the EEG is increasing, or an analysis of what we call an amplitude EEG, where you look at the power, the frequency using just another scale. All these processed quantified EEG allow you to have a view on the EEG on a larger period of time. Sometimes on the screen you have 2 to 3 hours. You can easily identify, at least for people who are trained, changes or main changes in EEG, which could be, of course, be looked as a raw EEG and be interpreted as main changes in EEG function. Just to make an example, can neuro ICU nurses use a quantitative EEG to adequately detect seizure at the bedside? And so this is the raw EEG, which most of us are unable to read. On the right side, you have this power and frequency analysis with a change here in frequency, which correspond as indicated by the arrow by a seizure. And in this study, of course, the nurses were able to identify the seizure. And as the seizure was identified even 2 o'clock in the morning, the physician could intervene, and of course, giving an anti-epileptic drugs, benzodiazepine, to treat the crisis. There are several studies which are reported and meta-analyzed in this recent review in neurocritical care from Andreas Kramer in Canada, where quantitative continuous EEG was evaluated to see whether if the neurophysiologist was the gold standard, other people, in particular nurses or trained non-neurophysiologists, could read the EEG, the quantitative EEG, and easily identify seizure. And you see in this meta-analysis that basically the specificity was 90% with a 94 negative predicted value, which means that if there is no major changes in power and frequency in EEG, you may be almost sure that you are not missing a big and prolonged seizure. Of course, there might be artifacts. This is why the positive predicted value is limited to 75%. Sometimes we look at some changes in frequency, it's just a muscular artifact. This could be interpreted by the an expert as the occurrence of seizure, maybe giving an inappropriate therapy, but these are again the limitation of application of EEG at the bedside. So moving from point 1, which is detection of seizure, to point 2, which is the extension of EEG monitoring in other indication the seizure, to point 3, which are the technical evolution which would make EEG more available in terms of devices, personnel, trained people outside neurophysiologists, 24/7 availability, and the quantification of EEG tracing using software. Now, of course, the question is, okay, everything this is nice, but as the ICU physician and nurses are those who are at the bedside all the time, these should be the people who would be ready, should be able to read this EEG and use it at the bedside. Why? Because if you use a monitoring at the bedside, the idea of the monitoring was to detect early neurological worsening before the brain damage occurs. So if you have an EEG monitor, no one looks at the EEG, and just 10 hours thereafter, the neurophysiologist will tell you your patient has the seizure for 2 days, for 2 hours, or there is an asymmetry of the EEG suggesting DCI since 8 hours, you will intervene too late. So the only way to make this EEG monitoring a true bedside available monitoring that can detect early neuroworsening, individualized care, and guide patients management is to make it available and readable for the ICU physician. Of course, this is the theory. The theory, as James Penny said, is splendid, but until you put it into practice, it's valueless. And we know now from different surveys that when you see which are the people that are able to read the EEG when EEG is applied in the ICU, only in 12% of cases, this was the neuro-intensivist, which is not just the intensivist, but the intensivist who works into a neuro ICU with some training, with some skills in reading EEG. Sometimes these are people who are neurologists, so they already have some skills in looking at the basis of EEG. I have no idea which would be the proportion if we would extend the survey to the general ICU physician. I would say less than 1%. One of the limitations to the applicability of the reading of the EEG to the ICU physician is this. I am personally unable to know whether this is seizure, this is artifact, the patient is moving. That will be too complex if you don't have read 1,000 or 2,000 EEG in your life, which is quite complex for a general ICU physician to be done. So we can, of course, buy an handbook of EEG, and you have to spend time to read it and train with an electrophysiologist, but I'm almost sure that most of us will not have the time to do it. So what you can do is basically simplify or ultra simplify the EEG to make it readable, like a little bit the electrocardiogram. We are not cardiologists, we cannot read all the ECG changes, but we are able to detect the major changes in EKG to, of course, treat or diagnose severe or large alteration of cardiac function. The same would be for the EEG. What do I want to know from the EEG to make it readable and understandable to the ICU physician? First, there is a normal amplitude of the EEG going from 5 to 100 microvolts, most of the time 10 to 100 microvolts. And if the amplitude decreases, there is a significant alteration of brain function and or brain perfusion. The EEG background is always continuous. There are no pauses, which means that if there are periods where the EEG activity is suppressed, then there is something going on. Most of the time, unless patients are awake or there is some other situation, the most of the time, particularly in the ICU, EEG should be symmetrical, which means the amplitude of the left side is similar to the right side. Persistent asymmetry should indicate focal lesion or the occurrence or an ongoing ischemic process occurring in the attenuated regions. And of course, the curing of seizure are typically associated with increased frequency and power of the EEG. So translating this into something that is practical, this is what I would expect from the EEG of the future. I'm not an expert on reading the EEG, but I can look whether the amplitude of the EEG is changing. So it's becoming more attenuated, more slower. That might, for example, tell the physician there is an encephalopathy. That might be hepatic encephalopathy, sepsis, for example, or maybe there's an excessive sedation. This patient says RDS, you're giving to these patients sedatives, the amplitude has been reducing, maybe the sedation is too much. If you have a measure of asymmetry, which is again the comparison of the amplitude between the left and right side, here you have an increased asymmetry from the left to the right side, you might say there should be a cerebral ischemia going on. There might be DCI, maybe an enlargement of a brain hemorrhage. And then I need maybe to do a CT scan to understand what's going on. And use the burst suppression ratio, which is the amount of a background which is totally suppressed, either as a prognostication after cardiac arrest, as I told you, or again as an excessive sedation. Excessive sedation would result in suppressed EEG or burst suppression. And finally, the occurrence of increased frequency and power can be, for example, seizure. And you see, these are very easily to detect the color, and we are very able to read colors when it's nicely presented rather than reading the raw EEG, which is very, very complex. And of course, if in the future the industry will be able to provide us this kind of screen with some alarms telling us that something going wrong in this parameter of EEG, please take care, read it with the neurophysiologist at home, or do this additional diagnostic procedure. This is the way where the EEG could be really available at the bedside to implement the neuromonitoring on these patients. Of course, there are caveats because we cannot use a too much simple EEG. We know, for example, that if you use a 2-channel EEG, there will be totally a mess, for example, in detection of a seizure, and even for the monitoring of sedation, that could be some limitation. Of course, you have to understand that the ICU is a hostile setting. So if you have an ECMO, if you have ECG, if you have shivering, there might be artifacts. So one of the things where the ICU physician in the future should be prepared to detect when they want to be, let's say, expert in quantified EEG is basically to recognize artifact. If you are unable to recognize artifact, you will not be able to use properly the EEG in these patients. Of course, this should be integrated together with other variables because the use of EEG together with other variables might be helpful to understand how changes in brain physiology could be secondary or not to changes in systemic physiology. This is feasible. I just present rapidly data from Monza. These are data from my friend Giuseppe Citterio, who has integrated this simplified EEG in his ICU. The data goes to a web server. It could be read by neurophysiologists. And this question was, can we train people who are not electrophysiologists? These are people working into the neuro ICU, could be physicians, nurses, or technologists, and see whether they are able to recognize the main changes on quantitative EEG using a webline online application, so they are not influenced by the electrophysiologist. Well, these are the main results. So this is before and after the training. Recognition on artifact, this is the percentage of agreement with the neurophysiologist, which of course is considered as the gold standard in this study. And you see here, artifact from 40% to 95%. Excessive sedation, 38% to 90%. The symmetry or asymmetry of the EEG from 70% to 80%. In the occurrence, of course, main seizure, 54 to 80%. You see how just going for a few hours course using very easily prepared modules and having a platform available will allow these non-neurophysiologists to, in most of the cases, agree with experienced neurophysiologists, identifying again few parameters from EEG. We're not saying that these people can read EEG, but they can interpret main changes in EEG. Another experience from Rome, which has not been published, from the Neuro ICU in Gemelli Hospital in Rome, and I thank our colleagues to share with me their results. They basically made the same approach. They had a teaching session of 1 hour to recognition of main EEG patterns, and then they tested people who are not experienced to see before and after how this would result in recognition of these main EEG parameters. And these are the main results. There is an agreement of 90 to 80% in recognizing the background of EEG, continuous, discontinuous, burst suppression, the asymmetry of the EEG, a little bit less maybe for seizure activity because these are more complicated to detect, but again, with a decent value of recognition of EEG, as I told you, the positive predictive value even in ICU nurses strain is no more than 75%, which is similar to what is published into the literature. So using quantitative EEG in this case can enable patients who are not neurophysiologists to report most of the EEG changes that we consider to be relevant for critically ill patients. And then we started from seizure. We moved from other indication into the ICU. We tried to improve the quality of G analysis. And then we understood it is possible to train ICU physicians and ICU nurses and the ICU personnel to make them able to read the EEG. Which will be the evolution? Well, the evolution will be kind of EEG 5.0, which is more the future because it's not available yet, as we have a point of care ultrasound. Patients arrive into the ICU, I take my ultrasound, I do rapidly the brain, the vessels, the heart, the thorax, the abdomen, the aorta. So I'm able to rapidly evaluate as a point of care different organs which might be altered because of sepsis, hemorrhage, cardiac arrest, or whatever. Well, can I do the same as a point of care EEG? So I use a device that is placed on the patients for a few hours, immediately, very early after the ICU admission, and as a point of care, give us a picture of EEG function and brain function in these patients. Well, this is the main aim of the LETITIA study we have conducted with the support of Neon Coden in my department, and Lorenzo Peluso is one of my senior research fellow who is responsible for this study. The question is, which is the value of early EEG monitoring placed on critically ill patients admitted with encephalopathy where the continuous EEG is not routinely indicated? And of course, which is the reliability of the EEG interpreted by the trained intensivist when compared with experienced neurophysiologists. Just to tell you how it worked, so we included prospectively patients with the ICU admission with a GCS equal or less than 14, where we could immediately place after the admission this simplified 6-channel wireless continuous EEG. For 8 to 12 hours, we excluded, of course, patients where there was scheduled surgery or where the full G were placed, basically cardiac arrest, SAH, trauma, where those in status epilepticus, where those patients where a full EEG was indicated. And again, as in previous studies, we looked at some patterns of EEG which could be identified by the physician: EEG background, seizure, periodic discharges, reactivity, and asymmetry. So these are patients, you know, 105 patients. The manuscript is in preparation. Most of them are ventilated, 20% of ECMO with an ICU mortality of 34%. So it's a very severe patient population. And you see, of course, there are patients with some forms of brain injury. Most of the patients are patients with medical ICU admission in shock with different origins, and 30% are isolated IDS without hemodynamic compromise. And you see that even in these patients where there is no clear indication of EEG, you're still able to find 19% of background, which is discontinuous or with burst suppression, suggesting an ongoing brain injury or an excessive sedation. 6% of asymmetry, 30% of loss variability. This is an example of burst suppression. This is an example of suppressed EEG we found in these patients. Is again an EEG in the patients with a severe encephalopathy, a very slow EEG background, suggesting an ongoing process in these patients was a metabolic encephalopathy as a reason for this EEG tracing. What we also observed is that, of course, you might expect that most of all of these alterations are present in patients with brain injury. Well, we found that 36% of patients with ERDS had a non-reactive EEG, and 24% of them might have this discontinuous suppression background, suggesting again maybe an excessive sedation of a secondary brain injury that might be associated in some patients with the ERDS in case of severe hypoxemia, for example, or other complication related to the ongoing reasons for ERDS. Of course, it's not the perfect situation. We might have artifact in some patients, you might have technical problems, and especially prolonged EEG monitoring might have some cutaneous complications. It's important again to improve also the technology and better select the patients to understand how this point of care EEG might be implemented. So in conclusion, and I try to stay in time, so hopefully to have at least 1-2 questions. The role of EEG has significantly evolved over time. EEG and quantitative EEG is part of a multimodal approach where each of these monitoring systems give us information on some characteristics of brain function. EEG has a spatial temporal resolution, very accurate way to assess seizure. It can be important to assess brain perfusion, prognostication of cardiac arrest, anesthesia, for example, and even assess the severity of metabolic encephalopathy with the occurrence, for example, of periodic, generalized, or lateralized discharges. I try to show you that the evolution of EEG is towards the interpretation and improvement of technology. We need to have a processed EEG to be able in the ICU to read hours and hours of EEG tracing. And the future will be to make ICU physician, of some ICU physician, able to read or to recognize main EEG patterns, and with disease patterns maybe in the future evolve towards the point of care EEG in the ICU. I think that these 2 last points, the fact that the ICU physician can read EEG and the implementation in selected patients of point of care EEG as an early monitoring and assessment tool to look at brain dysfunction in selected patients is the future of EEG in the ICU. I thank, of course, my colleagues, Lorenzo Peluso, my head of department, for the support, and Nicola Gasparte, and all the neurology and EEG team who support us with EEG monitoring and interpretation in the bedside for these critically ill patients. Thanks a lot.